Hello, today we'll be talking about renal colic. The learning objectives for today is to describe what the typical presentation of renal colic is, what are some of the red flags, symptoms associated with renal colic, and what investigations are needed when you suspect a renal colic. How do you manage these patients in terms of the initial and the definitive management, and understanding the guidelines, and the pathways. We would look at this presentation from the perspective of an SHO, a senior house officer, who is working in the urology department and has to be the first on call in seeing patients and managing these patients initially. For the content, we'll follow this outline. Renal colic is a very common urological presentation. It's probably one of the commonest presentations you will see as a urology SHO, either working in the emergency department or taking the acute presentation from the emergency department. And usually, stones in the kidneys are often asymptomatic. A lot of the presentations that you will be called for to see will be those that have an obstructing stone in the ureter. And the most common locations for this obstruction is either the PUJ, the pelvic brim, or the VUJ. This is an image that shows the common locations for the obstruction, showing the PUJ, the pelvic brim, and the VUJ. Like I said, it's a very common presentation. However, you must be careful to differentiate this from a liquid triple A, that's an abdominal aortic aneurysm. You don't want to be caught missing a triple A working as a urology SHO. How do these patients present? Usually the pain is sudden, and characteristically the pain will be a loin to groin kind of colicky pain. Sometimes the pain may radiate to the testicle. So be careful about those patients who come in with unilateral testicular pain, but also may have this vague flank pain, negative urine dip, and probably a drop in their EGFR. This should raise alarm bells in your mind that could this be a renal stone that's presenting. Usually the pain is severe and often the patients can't even sit still. Some other symptoms patients could have hematuria, which could be microscopic or visible hematuria. And some of these patients could be quite unwell and present with symptoms of sepsis or symptoms of an acute kidney injury like muscle cramps, reduced urinary output, and just general malaise. Past medical history, some of these patients could have previous history of stones, and sometimes when these patients present, they could tell you this pain is very characteristic to the pain I had when I had a previous kidney stone, and this could point you in the right direction. How do you examine these patients? Usually, these patients may be in distress, and like I said, they may struggle to sit still. An abdominal examination is very useful at this point and could reveal flank tenderness. If at some point you suspect or you feel a pulsatile abdominal mass, this could be a triple A and should be managed carefully. Also, the external genitalia examination could be unremarkable because the pain in the testes could just be a referred pain. You screen these patients. First of all, you want to rule out that they don't have a triple A, and then you assess for any hemodynamic stability. The history will be consistent with renal colic, and useful investigations will be a urine dip and blood test like full blood count using is INR and CRP. The next would be to perform a CT KUB for the patient. What are some of the red flags? Some of the red flags in patients present with renal colic would be if the patient is septic, if it's an obstructing stone in a single kidney, if a patient has moderate to severe hydronephrosis, or if it's a bilateral obstructing stone or pain that's not controlled with analgesia. These are some of the presentations that should make you quite concerned about these patients and likely want to get senior support for these patients. When do you escalate to a senior? You should consider escalating immediately to a registrar if it's an obstructing stone and the patient appears to be septic, or if it's an obstructing stone in a single kidney or a bilateral obstructing stone. You should escalate to registrar soon enough if it's an obstructing stone and there's also an AKI or there's severe hydronephrosis. If a patient has renal stone and the pain is not controlled with analgesia, you should optimize this patient analgesia and at some point let the registrar know. Admit patients who have red flag symptoms in hospital. What else could it be? Other urological causes of urological causes of flank pain could be a ureteric tumor, a PG obstruction, or it could be a pyelonephritis. Other causes could be an appendicitis, an ectopic pregnancy, or a ruptured ovarian cyst. How would you want to investigate these patients? A bedside urinalysis is important, plus or minus a urine MCS. If the patient could be pregnant or of childbearing age, it's important to do a beta HCG for this patient. You want to monitor the urinary output for this patient, especially if you suspect this patient to be septic. Bloods for this patient would include full blood count, use an ECRP, clotting profile, and possibly blood culture also if the patient is suspected to be septic. And if it's confirmed that the patient has a stone, a metabolic screen for this patient, including calcium and uric acid, is also important. The gold standard for investigating patients with a suspected renal stone is a CT KUB. If the patient is pregnant or in children, an ultrasound KUB should be requested. How do you manage this patient? Initial management for this patient will be analgesia. And non-steroidal anti-inflammatory drugs like diclofenac are found to be very helpful and extremely effective in managing this patient's pain. But other analgesia options are also available. You also want to measure this patient fluid balance carefully and then address any red flag symptoms like we've discussed. Definitive management. Usually in an emergency setting, a patient who has an obstructed kidney most times will need some kind of decompression of the kidney. And this could be by either a nephrostomy or a stent. And this would depend on the patient's overall presentation, comorbidities, local availability in that trust. However, this should be a consultant decision. But just so you are aware, in the emergency setting, the management would be likely a nephrostomy or a stent. Definitively, the management options include an extracorporeal shockwave lithotripsy or a ureteroscopy or a PCNL, depending on the location of the stone or the size of the stone. This is an image that shows an ESWL, and this is essentially shockwave that is directed at the stone to try to disintegrate the stone and could be in one or a couple of sessions. It could also be a URS or a PCNL. For ureteric stones, stones that are less than 5 millimeters are expected to pass, and conservative management could be tried for these patients. Stone less than 7 millimeter could pass, but the chances of them passing are lower. This is an image that shows a ureteric stone. Stones greater than 7 millimeters are unlikely to pass, and surgical intervention are usually required for these patients. This is not a hard and fast rule because in some patients, some 2 or 3 millimeter stone may struggle to pass, and some 5 or 6 millimeter stones may pass. But this is just a general guide. Definitive management, like we've said, depending on the location of the stone, could be an ESWL, could be a URS, also depending on the size of the stone. In conclusion, renal colic is a common emergency. It requires rapid differentiation from AAA, especially if you're seeing a patient in the emergency department. If you suspect a AAA, raise an alert for that patient for someone senior to review the patient. It's important that you're able to recognize the red flags for the patient that we've discussed. Request the appropriate investigation, and CT KEB is the gold standard, but ultrasound should be considered in pregnant patients and in children. Give them adequate analgesia, which usually includes non-steroidal anti-inflammatory drugs. And then the definitive management depends on the size and the location of the stone. Thank you.